Hello, welcome back to another episode. Here I am with John again, and today we're going to talk about our topic is the big question. Such an interesting question is, what are your long-term plans? The 5, 10 year long-term plans that comes as a common question during interviews. So here we are to tell you why are we doing what we're doing now, and this is 5 years, 6 years out of residency or after starting residency, and why it seems that we are more geared towards internal medicine, family practice, or primary care. Well, yes, because we are doing that, and a lot of international medical graduates they are focused on primary care specialties, say pediatrics, family practice, internal medicine. Some of them, not a lot of applicants go to surgery or apply to ENT or ophthalmology because those are more difficult ones to get.
More competitive.
And they most of the times don't offer J1 visas. So we don't see that many applicants going to those specialties. We do know what they do on a day-to-day basis because as hospitalists we deal with them for consultations on our patients. But the question of how on the long-term plan for you as an applicant has to show that you know the system, that you know the American system, and it has to show your commitment with the community that you are going to be training at, the place that you will be training at, and maybe that you could be of use to them, because some residency programs, most of them, I would say most of them, at the end of your training, at the end of this class training, they will try to keep one or two of the residents as part of their faculty, as part of their working force of hospitalists, primary care in the area. They would love to keep you as a primary care in the area. So let's talk about that. The first thing I have to say is that as an internal medicine graduate or as a family practice graduate, you can be either a family practice doctor or an internist.
Yeah.
Or, no, let me say that again. You can be either an inpatient doctor, which is called a hospitalist, or you can be an outpatient doctor, which is called a primary care provider, most of the times known as the family physician. Or the third path is a hybrid, where you can do inpatient work and outpatient work. That's seen on the older generation of doctors. They like to work super hard. They like to be able to have that continuity of care that outpatient practice offers, but they also like to be involved on inpatient medicine because that's where they train. It's very exciting to be in inpatient medicine. So I see how some people wouldn't like to leave that at all, but for what I've seen, it's a lot of work. So John, why did you decide to go primarily into inpatient medicine?
Well, I trained at Arrowhead Regional Medical Center, which is a predominantly inpatient program. I enjoy inpatient medicine because I would say it's like a more upgraded emergency medicine physician, because you treat them during a prolonged hospital stay, maybe 2-3 days max. Sometimes it could be as long as a week, just depending on how severe their illness is. But once you take care of them during that period of time, you're not responsible for them in an outpatient setting, meaning you're not there to set up their further appointments with their urologist or any other specialty physician. Once you treat them in the hospital, you're done.
Once you fix
you fix their problem or the reason why they're in the hospital, then you're no longer responsible for them as a patient.
Because the reason why we came to your hospital, to an acute care setting, is because something was really life-threatening, right? Something was out of what could be tolerable to be to be seen in a doctor's office. Let's say severe shortness of breath with hypoxia, and a fever,
Mm-hmm.
and then you see him and you think it's sepsis, and the blood work confirms it's sepsis. So that patient had to stay. You gave antibiotics. You called the right people to intervene,
Yeah.
and then you send this patient out, and you don't see him again.
Yeah, that's
Okay.
pretty much one of the big things, yeah. But also, inpatient medicine is more complicated. You don't always get these patients like in outpatient setting where they come in with type 2 diabetes management, or, you do a diabetic foot exam. You do it here in an inpatient setting, but not as frequent.
Yeah, we usually just take care of
Yeah.
the imminent
acute setting,
problem,
yeah.
and then we focus on that, and then our goal is to send them out as soon as we can
Yeah.
in what could be a safe way to discharge. One other thing that I like about inpatient medicine is that you are constantly exposed to specialists that contribute to your care, and by doing so, you learn from there.
Yeah.
You're also always exposed to new people, new grads that come with new knowledge and a lot of energy, and you learn from them.
Yeah.
So that's one of the reasons I like
Yeah.
inpatient medicine, and I like the thrill of inpatient medicine. I like the excitement that comes with being in an acute care setting.
Mm-hmm.
To be honest, the part that I didn't like much about outpatient care, it's the continuity of care part.
Yeah.
It was very difficult to me to keep track of one patient's family, and one patient, his family, his goals of care.
I think it really depends on a certain person, somebody that wants to develop a relationship with that patient long term.
Yeah,
That, and also it's not for everybody.
yeah, exactly.
Exactly what you're saying is that, it's that continuity of care. There's a lot of things involved in that. You have to remember things from your past notes, and it becomes complicating in and of itself. And plus, it can be draining for some people.
Emotionally draining.
Emotionally
right?
draining, because you're going to see this person progress through their disease process.
Yeah, I see people that do outpatient or continuity of care to be the nicest people,
Yeah.
because they're really
Yeah.
involved to the patient's family.
Mhm.
They call them all the time. They give them updates all the time. They become part of their families. They
Exactly. I mean, there's nothing wrong with it. I think there's all that, what you mentioned earlier about there being hybrid, where you own your own private practice and then you admit your patients, but that's very old school, like you mentioned.
So
Yeah.
long term. One of the reasons why I didn't want to do outpatient, it's because of that, because of the load of patients that you get. If you have your own practice, you have to get a big load of patients
Yeah,
to
you
make
do.
it worth.
You see about
You're-
20 to 24 patients a day on your list, and that's a lot. 24 different patients a day
So
for 5 days a week is a lot.
you need that volume to make it worth,
Yeah.
and to have your practice thriving. So that's one of the things I was thinking. Outpatient medicine seems a lot of work, a lot of paperwork for insurance purposes. You need to authorize things with pharmacies, medications. You have to call insurances. Whereas in the hospital, someone does it for you. There's a case manager that does it for you. And because it's an acute need, it's most of the times approved. So the extra work that outpatient doctors have, I don't see
Yeah.
that much. That's one of my reasons is that I like the excitement of internal inpatient medicine. I like our current schedule.
Yeah.
Hospitalist medicine, inpatient medicine has a very cool schedule that is called the 7 on, 7 off.
Yeah.
I don't know, you guys would see that on your rotations during your observerships. Is that 7 on, 7 off means that we will be working for 7 days, and then we will
Off for
stop
7,
working
yeah.
for 7 days. So that, to me, that's great. On my 7
Yeah,
days,
you're only working half the year.
Yeah,
And that other half of the year, you could do whatever you want to do. You could either vacation, or if you really want to do another like side jobs, you can do that too. So
Yeah.
it's very much an open opportunity.
on your 7 days, what do you do on your 7 days?
My 7 days, it really depends. Like I'm currently working per diem where I do my residency at. So I wanted to. I didn't want to dedicate full time 100% to academic medicine, but this opportunity to work only 7 days on, 7 days off, that last the 7 days I'm off, I'm able to work with residents and teach. That so then I'm not working as a full time academic, but it's part time, so that's good. And other days I'll be working at Kaiser and stuff like that, or another community hospital.
Wow.
Yeah.
That's a lot of work. I only rest. I don't do much on my days off.
But I'm young, so I try to do as much as I can. I'll probably be at that point. Yeah.
You're only 34?
32.
32? Oh, I'm 35. Anyways.
Yeah, you're still young.
So that's he does all that. I on my 7 days I like to go back to my country. I like to work in my backyard. I don't really do much these days. I used to, on my first years, I used to work super hard. I was involved on hospice. I was involved on extra shifts here and there, per diem work, which means that you work for another facility on a as needed basis. So that's a very good way for us, for hospitalists, to ramp up our year income. Outpatient medicine has to work Monday through Friday most of the times. Depending on how you arrange for your schedule, you can do Monday through Thursday. You could do Monday through Wednesday if that's what you sign a contract for. But if you do that Monday through Wednesday, first, you're not getting a full-time salary.
Yeah.
You're going to get a part-time salary. So that means less benefits like insurance coverage, medical insurance coverage, less salary, which is a big thing. And if you are on a need for a J1 visa, H1 visa sponsorship, you won't be able to get that, because to prove that you are on you qualify for a J1 waiver at the end of your residency, you will need to be 40 hours a week, and that has to be proven. It cannot be done if you say you're going to work Monday through Wednesday. So if you want to be an outpatient doctor, it's going to be Monday through Friday if you need a visa, or you need a full salary. And as an outpatient, it's very hard. As an outpatient doctor, it's very hard to get those side gigs that what we do.
Because you work Monday through Friday.
You work 8 to 5. That's how an outpatient doctor in primary care has to work. That's their hours.
Yeah, that is.
So that's a little bit of long-term plans. The community setting that you will the community that you will be working at, it's also part of that long-term plan, because you will choose to where to work, right? You will choose where to go. You can choose to go to a rich area, or you can choose to work to an underserved area and serve a whole different population. The underserved area, the marginalized area, the area that serves vulnerable populations, is a little more work, and it involves a different medicine. The richer areas won't have much of that, but they have a little more of work in terms of how you approach the cases that you will see. Our area, the area we currently work, is a very poor area, very multi-ethnic.
Multi-ethnic. I think there's some diversity too in regards to there being an upper class too from Claremont and things like that. So you have a diversity here.
Yes.
As opposed to a county hospital like San Bernardino County, where I did training, everyone was basically underserved.
Yes.
Yeah. They had lack of access to health care, so you had very sick people.
Yeah. For what I've seen on all these several years I've been in this area, we have a big need on understanding of diabetes management. We have a big need of early initiation of palliative care work for patients. We have a need of understanding for the homeless and their needs. So those are things that you can use on your interviews. You can hopefully the conversation we're having right now serves you to understand
your future plans.
Your future plans.
That way you understand what you're going into.
that way you can present to that question with a solid answer. So let's get an answer from John and see what he gets. Okay,
sure.
so let's say this is your interview day, and I ask you, hey, let's say this is 8 years back when you're applying to residency, and
sure.
you're your match season, and
Yeah.
we ask you, hey, what are your long-term plans? Where do you see yourself in 5 years after finishing residency?
Yeah. So looking at your program and studying exactly the things that your program offers, I saw that at Arrowhead that you guys served a predominantly underserved community. And that is something that I want to do 5 years from now, is that work in a community that serves the same patients that you're serving. So ideally, the program that I'm looking into is one with a 450 bed to 600 bed hospital, which Arrowhead offers. I want to work in a hospital that offers inpatient care, which predominantly this program offers a very high amount of inpatient care. And also, I also enjoy the fact that there's not that many specialists. And the reason why that I enjoy that is because that not having that many specialists means that as a resident, I would have to learn those things, like endocrinology or cardiology and things like that. And I would have to decipher whether or not those needs are needed through those specialists. So by having through your program at Arrowhead, by not having those specialists involved, it broadens my understanding of these different specialties. So by having all these different things, these different beds, these number of beds that you have, the type of population you have, the lack of specialists, which is not a bad thing. To me, it's not a bad thing. But having that available to me means that I'll be a more well-rounded physician, so that in 5 years, when I'm practicing out in the community, like somewhere in Pomona or somewhere in San Bernardino County, which is my future plans, I'll be able to apply those things I understand from your program and apply it to my future practice 5 or 10 years down the line.
You're gearing your answer towards inpatient medicine.
Inpatient medicine, yeah.
So you could say at the beginning that I would like to be a hospitalist working
I think it'd be, if you want to make it short and concise, you'd say I want to be a hospitalist in 5 years serving this type of community.
Okay.
But also highlighting the fact what that program you're applying to, what resources they have. And some people, you can even highlight some of their weaknesses that they have, but highlight it as a strength.
Oh.
So for instance, at Arrowhead, one of the things that people were talking about was that they lacked the specialists. Like for instance, here we have a dedicated endocrinologist, or like somebody or CT surgery and things like that, Whereas in Arrowhead, we didn't have those things. And a lot of those people were talking about that as being a negative. But when I was interviewing with the program director, I highlighted those things as positives, showing that I can work through those issues, those weaknesses that they have, and make it a strength for my own, meaning I'm learning on my own.
Oh, that's a good thing. Okay.
So that's why it's so important that when you do answer these 5 to 10 year questions, you're taking into account the programs you're applying to and what they can offer you that can help you 5 years down the line, if that makes any sense.
Yep.
Yeah.
Sounds good. Okay. Thank you for that.
Yeah,
That's
no
a
problem.
great answer.
Yeah.
I'm going to start advising people based on your last lines.
Yeah.
Okay, so that's inpatient medicine, outpatient medicine for the family practice and internal medicine docs. It's about the same for pediatrics.
Mm-hmm.
For OBGYN, it differs in the way that as an OBGYN,
OBGYN is more, it's geared towards people who want to, one, serve one type of population, women. Two, the other thing is that if you enjoy having a surgical specialty as well as some primary care in addition to that, that's where you want to go into OBGYN.
Yeah.
Is that you have that surgical knowledge as well as that primary care where you're,
But you can also be OBGYN. You can also be
just straight up gynecology too, if you want.
You can be a hybrid of outpatient and inpatient.
Mm-hmm.
Inpatient work will be rounded in the hospital for your deliveries, your post-ops, for C-sections, what's that? Hysterectomy patients.
Yeah.
What else they do? they do a lot of cool procedures.
They do a
too.
lot of good procedures.
The robotic Da
hysterectomy,
Vinci and
the only thing is that you have to be okay with just serving one population.
Yeah.
That's part of your plans. And if you're okay with that, then all
So-
for it.
and they OBGYNs, they can also be inpatient only. They can be,
Yeah.
there's a new thing towards having OBGYN hospitalists.
Yeah.
That they only stay in the hospital all day. They do all the deliveries. They do all the emergency C-sections.
Yeah.
It's a very cool, and it works as much as we do, 7 on, 7 off. They have a great salary, great time off.
And they also have like fellowship programs too. Like they can also do fertility and
Same?
genetics and things like that too.
Then what about the other specialties? Surgery, they have to have a combination of both for the practice to thrive. The
Yeah, they have.
outpatient and inpatient. They do a lot of work. They run back and forth from their office to the hospital to do their surgeries.
Yeah.
They schedule their surgeries, be on call in the hospital. So they actually have to do 8 to 5 work in the office, and they have to get to the hospital on their break times to see their patients, they schedule their surgeries. And that's the hard work ones, the hard working ones. The other ones that would like a little more relaxed time, they can mix their days to accommodate those needs, but that also comes with less salary. So yeah, a surgeon can make twice as much of what an internist can do if we try to say that we work the same hours or same days, but they have way more work and a lot of stress. I think it's a very
Yeah, I mean,
stressful-
it really depends on the type of person you are.
yeah.
Just the best thing is to just envision yourself 10 years from now. Do you envision yourself cutting every day and doing surgery every day? So it just comes down to vision.
Yeah, the same applies to ENTs. The ENTs also need a hybrid practice
Yeah.
of inpatient and outpatient. Inpatient for the procedures.
So is urology and
Exactly. All the surgical procedures,
all the
right?
surgical requires that hybrid.
Hybrid mode. So yeah, for this kind of question, where do you see yourself in 5 years, 10 years? I think the key to this is, like, for any question that you will provide during interview season, is an honest answer that's a well thought answer. More than the looking for the right answer, a well thought answer. And hopefully with this content on this video, you can get the knowledge of what you will be talking about, and give them a solid answer. And if they come back with a question like why this and why that, then hopefully by that time you have this answer on you.
Yeah.
Well, thank you very much. It's
Yeah.
a great conversation. Bye,
Thanks,
guys.
Bye.